Good morning, everyone. I'm Debbie Lindis. I'm the manager of the Healthcare Delivery System Group at the Office of Healthcare Affordability. I use she, her pronouns, and welcome to the 16th meeting of the OHCA Investment and Payment Workgroup and our 4th meeting focused on behavioral health investment. Thank you all for joining, and as usual, please introduce yourself in the chat with your name and your organization. So today we'll spend almost the entire meeting discussing behavioral health investment benchmark priorities to inform our upcoming work on defining behavioral health spending. And thank you to so many of you for responding to our pre-meeting poll. We'll use those results to guide our discussion today. And then before we adjourn this morning, we'll preview our agenda for our November meeting. Here's a recap of our meeting format. We appreciate and consider all the thoughtful comments you put in the chat during these meetings, and we ask that you provide your organizational affiliation with your comments. We might not be able to respond to every comment during the meeting, but we do review all of the chats and use them to inform our work moving forward. So we appreciate your engagement. And as a quick reminder, here are all of our work group members and the range of stakeholder perspectives they represent. So before we move on to today's topic, we're excited to share that the Healthcare Affordability Board adopted our recommended primary care investment benchmark at their meeting earlier this week. The benchmark was approved as presented and as shown in this slide. We are very grateful to this work group, the advisory committee, and other stakeholders for their important contributions to this work. So thank you. So as you know from prior meetings, OHCA's behavioral health investment work is guided by our statutory requirements and goals that are outlined on these next two slides. We've reviewed these before, so I won't spend much time on them today. But just as a reminder, OHCA is required to promote sustained system-wide investment in behavioral health care, and in doing so, to measure the percentage of total healthcare expenditures allocated to behavioral health and to set spending benchmarks. To complete these tasks, we'll need to define behavioral health spending for the purposes of measurement and determine what portion of spending will count towards the benchmark. And those decisions will depend in large part on the priorities we set for that sustained system-wide investment. OHCA's mandate to measure and benchmark spending is a component of system-wide efforts to improve health outcomes in California. In the case of behavioral health, our statute requires us to promote models that integrate behavioral health with primary care and with broader social and public health services, to encourage the adoption of alternative payment models that enable improved access and team-based approaches to care, to help reduce disparities in behavioral health, and to expand access using telehealth and other solutions. And this is the logic model we've looked at before, which shows OHCA's role in improving behavioral health outcomes through its measurement and benchmarking activities. Our work at OHCA supports other stakeholders' actions, which we hope will result in achieving our system-wide behavioral health goals. And here are the proposed goals for improved behavioral health care that we reviewed during our last meeting. We can refer to these as touch points as we get into the discussion of behavioral health investment priorities. And now I'll pass it to Margareta to share the results of our poll and lead today's discussion.
Good morning, everyone. Thank you, Debbie. So in this portion of today's meeting, we will review the results of the poll that we sent out about 2 weeks ago to get all of your feedback or to get kind of assess your priorities for the behavioral health investment benchmark. So starting here with just an overview of and purpose of today's discussion. Again, as Debbie mentioned, our charge is to measure behavioral health spending and how as we've noted during previous workgroup meetings, not all behavioral health spending is equal. So while some spending increases are desirable, potentially, especially such as office-based care, others are not ideal, like emergency department care for behavioral health conditions. So it's important for the behavioral health investment benchmark to reflect the priorities for where we want to see behavioral health spending. So our goal of the pre-meeting poll that we sent out to everyone was to get your kind of assess your thinking of priorities to help guide our discussion today. And the goal of today's discussion is to not define a benchmark, but to rather gather input to inform the behavioral health spending definition. So we wanted to take this poll of your priorities for the behavioral health investment benchmark to think, to guide us as we work towards developing our definition, because there's lots of different decisions we can make about how we define behavioral health spending and how we collect that data. And so after we solidify recommendations on the spending definition, we will come back and apply these priorities to setting the benchmark. So here today, we're talking about priorities for the benchmark, and then in our next few meetings, we'll dive into the definition and details about how we define behavioral health spending and how we would collect that data or implications for data collection in terms of how we define spending. And then we'll come back to the benchmark to have more detailed discussions. So today's meeting will be a little bit different than prior meetings. So less presentation, more discussion. We really want you all to share your feedback and why you responded a certain way in a poll if you're comfortable, and just share your thoughts about each of these questions that we have. So we'll briefly review the results from each poll question to prompt discussion, and then we'll open up discussion to hear from all of you. And then we also have time at the end for any additional thoughts and more open conversation for anything that has come up that we want to discuss further. And just a note that as we move forward with the conversation today and in later meetings, that the data OHCA collects for measuring progress towards the behavioral health investment benchmark will not be the only way for us to understand spending patterns for behavioral health spending. So, as we've discussed previously in some meetings, that some analysis, especially more detailed analysis, might be more appropriate for the healthcare payments database, and OHCA can collaborate with the healthcare payments database team to do more granular analysis compared to the aggregate spending data that OHCA would be collecting. And then also want to emphasize that OHCA is also undertaking an analysis of out-of-plan spending, and we'll share progress on that work stream as it moves forward with this group. So next, just want to move to a bit about the pre-meeting poll. So the poll included 7 questions, one that asked respondents to rank a list of options, 5 multiple choice questions, and 1 free text question that was optional. And we received 24 responses and 7 free text responses to the last question. Really want to thank you all for your responses. It's quite a good response rate, so we really appreciate all of your engagement, and thanks everyone for completing the survey. So moving forward to our first question. So the first question of the poll asked investment and payment workgroup members to order a list of priorities for increased behavioral health investment from highest to lowest. And the order of the options on the slide reflects the results. The bar to the right of each option shows the breakdown of responses received, and there's the categories or the color coding at the top. So generally, access issues were considered most important. So most respondents identified increasing access to the most appropriate care settings as their highest priority or their first choice for increased behavioral health investment. And increasing access to care for specific populations was the top priority for the 3rd highest number of respondents. And the second highest number of respondents identified integrating primary care and behavioral health care as their top priority. And increasing access for specific populations came in third, as I noted. And the fewest respondents identified the last two, which kind of tied for fourth in an odd way as their highest priority. So increasing access to specific provider types and decreasing out-of-pocket spend for behavioral health care. So I just wanted to pause here for folks to react to this ranking and the choices that came out on top. And, if anyone wants to share their reaction or, their perspective on the priorities for increased behavioral health investment, that would we would love to have just a discussion about how you all prioritize this and how you're thinking about this. Yes, Beth, go ahead.
2 points. In some ways, it's not a surprise that a work group that started off focusing on primary care would think integration of primary care and behavioral health is a high priority. I'm not saying I agree it's important, and it would be a better world if we got to a place where that worked the way some of the people on this work group envision it. So it's not that I'm dismissing the importance of it, but I do think the order of the work may have some effect on the result. The work that we have done as a work group, I mean. Second, and from a consumer perspective, the out-of-pocket spending to get necessary care is to us the biggest red flag of the failure of the system, that people are not obtaining necessary care as a covered benefit. We want to get to the place where access to behavioral health is as easy and as affordable as it is for physical health, which is still not great, but behavioral health is so much worse. And when I think about, no one would tell someone who had a really bad heart condition or a very serious cancer that they should go to the county to get care, unless they happen to be in a Medi-Cal managed care network that was anchored on the county hospital. But we do that and all sorts of other things. If you want timely mental health, pay cash. And to all the providers who are sitting there thinking of the long litany of reasons why dealing with insurance companies is horrible, that's part of what needs fixing. And I know how committed this administration is to improving access to behavioral health through people's primary coverage. And that should be part of what framed our response on why we think out-of-pocket costs are really an important indicator of the system not working well. Thank you.
Thank you, Beth. So just to recap or how I'm thinking about that is that decreasing or out-of-pocket spend is a signal that the healthcare system does not have enough access through coverage. And so
Right.
those are tied together for you.
Yeah. And it's, yeah. And part of the maldistribution in the system is the heavy reliance on private pay. We don't do that for primary care or oncology or cardiac care. And so I don't, when you look at it that way, I don't know why we do it for behavioral health. I know it's the system we have, and I know what I would say if I were a psychiatrist or a non-physician mental health professional about the barriers to providing good care. We hear those stories, we read those articles. So I'm not dismissing that. I'm just saying that's the system. Those are the sorts of things that need fixing as we think ahead the behavioral health benchmark.
Great.
Thank you.
Yeah. And it looks like Nicole, I see your hand up.
Good morning, everybody. It's Dr. Nicole Stelter from Blue Shield of California. I'm sorry, not on camera this morning. I'm a little under the weather, so not inflicting that on all of you. Just one comment, not in follow-up to Beth, but we'd ranked specific provider types, increasing access there as higher appropriate care setting, I think is absolutely right from a level of care perspective. And specific provider types, I think, is also challenging. And we were thinking in terms of children and adolescents, eating disorder, essentially subpopulations where we know we have greater need and even less provider access. So assuming provider access is an issue regardless, there are definitely subpopulations or diagnostic categories where we wanted to kind of call that out. So just weighing in on specific provider types.
Thank you. So the interest there is to increase access to specific provider types to care for specific populations or care for specific conditions?
Yeah, both. And then also psychiatry versus prescribing versus non-prescribing. I think those are all categories to explore versus just kind of blanket, outpatient care or something. So that's where we answered in that.
Thank you. Anyone else have other thoughts or reactions they want to share, either to how they responded to this question or to, how you're seeing the priorities in terms of the rankings? Ben.
Thank you. Benjamin Eichert from the National Union of Healthcare Workers. Just really want to echo Beth's comments. In the work that we're doing, I did not have an opportunity to respond to this survey, but really believe that decreasing out-of-pocket spending is a very high priority and can help address other access issues. We believe it in many cases is a root cause of lack of access for many folks.
Thank you. In terms of, looking at, it looks like folks, see increasing access and decreasing out-of-pocket spend potentially really closely related. Do folks have thoughts on how a benchmark might be structured to address these priorities?
This is going to sound simplistic, this Beth again, but if we can actually track out-of-pocket spend versus spend on covered benefits, I would think of it in a similar. I would think of it. The out-of-pockets ideally over time, and let's say it's a 10-year time horizon like we used for primary care. Out-of-pocket spend should go down while use of covered benefits should go up. And so it's that movement from one to the other, which is going to take some system adjustment and take time. And, the integrating primary care and behavioral health will work better when we have more access to primary care, and it's team-based care and all those other good things we've talked about. But that shift to making sure that behavioral health is covered in the same way, and I'm just going to keep using this simple example because I can understand it, as cardiac care or oncology, is the world we should be going to. Or labor and delivery. I mean, take your pick of any number of other areas of care. Thank you.
Thanks, Beth. And Sarah, go ahead.
Yeah, I'm trying to figure out how to articulate what. So behavioral health spend is a function of the cost per unit and the number of units of service. And so tracking from a benchmark perspective, both of those things separately, or somehow, because like the out-of-pocket spend relates to network adequacy, right? Network adequacy translates to providers willing to be in the network at the rates that the payers are willing to pay. And so understanding that those sort of economics around network participation somehow so I don't exactly know what I'm like saying here, but there's something there, right, around why aren't providers participating in the insurance market, right? And then you can stratify that by which type of insurance market. There would be Medicare, there'll be Medi-Cal, and then there'll be commercial. And some of it comes like, what are the rates that are paid to providers? And so understanding spend, like really looking at it both in terms of the total number of units of service provided and then the rate per unit, and understanding variation there is important to solving this puzzle, I guess, is what I'm saying. Because I agree with Beth that out-of-pocket spend is directly related to access. Like they cannot be, you can't untangle them, especially for the behavioral health services. So like what we benchmark, it can't just be I guess the total spend would be a blunt instrument as the benchmark.
Right. And I would add, the other thread we should not lose track of that I haven't mentioned is equity. Anything that requires people to spend money out of their own pocket is more problematic for people who have less income and face greater challenges in terms of access, whether that's disability, lack of culturally appropriate care, the list, I mean, we all know the list, it goes on and on, but all that's made worse when you ask people to spend cash. Thank you.
Thanks, Beth. Thanks, Sarah. Yeah, Dr. Gupta, go ahead.
Yeah, I just want to jump on to Beth's comment. So I won't say too much, but I'm completely in agreement with all the comments she's made so far. But one thing around the equity component I just want to highlight is equity actually looks very different around the out-of-pocket costs. So it's not only the traditional populations we think about when it comes to out-of-pocket costs, but it's also based on the specific plan that they have. And there's other groups that we may not think about as traditionally going to be left out of the system just based on overall income or assets, for example, or the zip code that they live in. But there's other groups that have these high deductibles, other things that we've talked about. And so I just want to double down on what Beth is saying too, on really being thoughtful about that piece being integrated for the out-of-pocket cost component. And then just generally agree that these go hand in hand. And if any group is charged to talk about the out-of-pocket costs, it is this group. There's a lot of groups that talk about access, and it's extremely important, but not all of them completely get into out-of-pocket costs with, I think, the nuance that this group could offer to the discussion.
Thank you. Yeah, I think our work on out-of-pocket spending is ongoing, and as soon as we can, we'll bring some of those the results as they relate to behavioral health to this work group. I think it's quite a challenge, and there aren't wonderful data sources to track out-of-pocket, out-of-plan spending. So it is definitely something we're tracking and working on internally, but it's one of those things where I think we'll have to kind of keep iterating and trying to find new ways to understand the out-of-pocket, out-of-plan spend. And then I think Stephanie, if do you want to jump in?
Hi, thanks everyone. This is Stephanie Berry with Anthem. I just wanted to point out, when we're looking at out-of-pocket spending, I mean, I agree with some of what Sarah was saying. It can be kind of a blunt instrument. We also need to be really careful about evidence-based care, because some out-of-plan spending is for situations that are just really not appropriate care, and we want to make sure that the behavioral health spending is in the right space. We're also just concerned overall, even in plan-based spending, of certain treatment facilities that have really preyed on populations with insurance and try to maximize what they can get from insurance companies with things that really aren't evidence-based practices, such as what we've seen with the Acadia hospitals in Florida and other states, where they've really held people behind against their will to maximize the money that they can get from insurance companies before releasing them. So those are other issues we really need to take a look at when we're talking about the total spend of behavioral health spending.
Thanks, Stephanie. Sarah, go ahead.
I agree with what Stephanie just said, and I was actually going to sort of say the flip side for behavioral health is also on the sort of lower end of the continuum. Like a lot of our traditional models of behavioral health spend and insurance is a one-on-one session or a group session with a licensed provider, right? So there's this assumption like that. I mean, that's kind of the main tool, but there are increasingly alternative options to that, or other levels of care like a coach, and that may be a adequate, or if not more appropriate, intervention for some populations. And so as we look at what we're counting, having, the model that it does take into consideration maybe alternative approaches to a 90832 and a 90837, right, which are the two therapy codes that are primarily on an outpatient basis. So the different applications or digital therapeutics or those types of modalities that insurance may be reimbursing. And then I'll just plug for California, we do have the unique context of the multi-payer fee schedule that's rolling out for school-based settings, and monitoring that and factoring that into this also will be important, because that is a large experiment that hasn't, there's no sort of template for nationally.
Thanks, Sarah. I think we'll go to the next few hands raised, and then I think we'll move on to our next question. But Carrie, go ahead.
Hi, Carrie Sanders with CPEN, and sorry, I hopped on a little late, but I did just want to kind of, plus one on the comments from Beth and others on equity, and particularly just pointing out that the burden of out-of-pocket costs, falls disproportionately on communities of color that are unable to access care that's culturally and linguistically appropriate. I think as we're thinking about spending, we support the focus on primary care and integration, and really trying to ensure that the spend is adequate to the need, and that we're also thinking about as we think about costs, that it shouldn't come at the expense of equitable care and investments on ensuring that folks can ensuring network adequacy, linguistic access, cultural access to providers that can really serve the population. So I realize that may be hard to do. But I think what we want to see is spending that actually results in folks being able to utilize preventative care at much higher rates than they have been and are able to today. Thanks.
Thank you, Carrie. Next, it looked like Kirsten. Did you have your hand up, or did you want to weigh in? Oh. Beth, do you want to go ahead, and then we'll come back to Kirsten?
Okay, great. Well, I don't mean to, thank you. I feel like I'm taking third helpings at the line. A couple of things. First, health access has always been clear on the physical health side. The care should be medically necessary, and the same would be true here. I think what's hard is because of the historic prejudice against mental health and substance abuse treatment, that there's a lot of denigration of the care, the people who need care, and I hope not as much the people who provide care, but I think it is, that stigma still lingers on, sadly. And so I'm not always clear. It feels as if the standards for medical necessity are more stringent on the behavioral health side. And that's not in any way to minimize preventive care or lower levels of care that are appropriate. The other point I'd make is part of the challenge, I think, of this work group is it's not clear what the right level of not just spending, but care is, appropriate care. I think that's part of the challenge we're grappling with. And so, you know, it's easy for me to talk in broad principles. Getting down to the kind of arithmetic Sarah Arnquist was trying to do in her head is going to be a lot harder.
Yes, we have
Thank
our
you.
work cut out for us. I just wanted to go back to Kirsten. Did you?
Oh, sorry. One other point
Yeah.
I want this group to, one fact that I know the OHCA staff is well aware of because I keep harping on it, but for this group, 80% of California families live on less than $146,000 a year. So when we think about access, asking people to pay out of pocket for behavioral health when they're living, when a family is living on $80,000 or $100,000 a year is just utterly inaccessible. So thank you.
Thank you.
Thanks.
Maybe-
It's Kirsten from the California Hospital Association. I think just one last point that I wanted to make, which I think I make every time we have a, a work group call, that the terminology behavioral health is almost too broad to be helpful, I think, in some cases. And we just want to make sure that once we start to really dig into how these things get measured, that we distinguish access to mental health care for example, mood disorders, which might look different, what your idea of an appropriate level of care is versus, for example, psychotic disorders or substance use disorders. I think we need to make sure we kind of keep track of needing to tease that apart, because appropriate, I think, as was pointed out earlier, may not just be that you're taking meds and going to a therapist. Depending on the type of actual behavioral health treatment, or I'm sorry, condition, appropriate might look different.
Thank you. Yeah, thanks for emphasizing that. And I think that relates to some of the other questions we had in the poll. So I think it just, I kind of understanding from this discussion that there's a strong focus in the work group for increasing access and, understanding and or, emphasizing the need, the relationship between increasing access and decreasing out-of-pocket, out-of-plan spend for behavioral health care, and that those two are, closely related and integrated, and that, we can look to, as we're moving forward, think about how we're measuring, increased access to potentially specific either care settings or providers. And we can think about how we would incorporate that into how we define and measure behavioral health spending. So really great discussion, and we'll keep moving. So we have more questions to cover. Here, this was our second question in the poll, which asked whether the OHCA behavioral health investment benchmark should focus on a specific area of behavioral health care, such as conditions, providers, or care settings. And we have some more specific questions later, so I probably won't spend too much time on this slide. And so here, a focused benchmark would mean defining spending by measuring measuring spending using a list of diagnosis codes, of provider taxonomies, or CMS place of service codes. This means that, data submitters, when they're submitting their spending data to OHCA, would filter their claims and non-claim spending by these codes when they submit. And so here, about half of respondents supported the idea of a focused behavioral health investment benchmark. About a third did not, and then about a quarter of respondents are, still undecided. And yeah, Nicole, go ahead, jump in.
Yeah, just a quick question. And I'm sorry if this is making you all repeat yourselves. I know we're working towards recommendations. Is part of those recommendations can also be that we revisit the initial definitions or measurements in, whatever time period. Is that correct? Or are we picking one and that's what we're doing going forward? End of story.
No, I think we would likely revisit our definition over time. I think there would be, simple revisiting, like, do we need to update our code set to incorporate new codes that exist now, or, codes that have changed or revised, things like that. And then I think over time, if there are kind of questions or concerns about, how we've defined behavioral health spending and what we're seeing in the spending and progress towards the spending benchmark, I think it would be logical for us to revisit the definition.
Okay, good. Because I think that's partially how we get to kind of the quote unquote first endpoint with this is picking what everyone can kind of agree on is the best starting point or the best couple of starting points. And I know that when we answered this, I think that was part of my hesitation about kind of coming down hard on one side or the other for specific, is wanting to know that this is, and I hate to say pilot or something to that nature, but because I don't want this to be a pilot either. So thank you for clarifying.
Sure. Yeah, I think just in terms of changing the definition over time, we just want to be thoughtful about how we do that in terms of comparisons over time and, comparisons against a baseline we've set, things like that. So it's just a process that we'll have to kind of iterate as we move forward. Anyone else want to share thoughts or reactions to the results for question 2? Okay, so we'll move on to question 3. So here we had more of kind of split or mixed responses. So question 3 asks whether the OHCA Behavioral Health Investment Benchmark should focus on certain diagnoses or categories for diagnoses. For example, the benchmark could focus on mental health disorders or substance use disorders, or even have a more granular focus, say, on opioid use disorder, anxiety, or depression. And here, the definition impact is that data submitters would be required to report their behavioral health spending by diagnosis or by diagnosis category. And as we discussed at last month's meeting, using diagnosis to define behavioral health spending offers advantages, including the ability to look at the distribution of a spending across conditions. It would also capture spending without greatly overcounting for behavioral health services delivered by potentially non-behavioral health clinicians, such as primary care providers, or in care settings, such as acute care hospitals. A drawback is that including diagnosis is not consistent with the methodology for measuring primary care, so this would be a different approach and a new approach. So if we go down the process of specifying behavioral health spending according to diagnosis, the work group would be taking up, lots of follow-up questions in future meetings. So one is whether the definition would consider only a primary diagnosis or would also include a secondary or a tertiary diagnosis to count in the definition. And then a related question is whether the diagnosis filter can be flexible in how it is applied across providers and settings, or whether it needs to be used in the same way for all providers and settings. So for this question, about 3/4 of the respondents were evenly split between whether the benchmark should or should not focus on diagnosis, and the remainder were undecided. So we had lots of mixed response here. Anyone want to weigh in here? And Jeff, go ahead.
Sure. So I agree with Sarah in the chat, like we could consider sort of broader buckets, and there may be some advantages there. Just from as a clinician, if you're starting to get more granular in diagnosis, especially with behavioral health conditions, there's a lot of questions about the validity of the diagnostic categories that we've created. Like if you talk to folks about the development of the DSM-5, there is lots of debate about how those buckets are created and the appropriateness of them. So if you start to really get too granular, you start to trudge into this clinical appropriateness dialogue that I don't think is the point of what we're trying to get into here. So I would just stay away from too much granularity, like going to the level of anxiety or depression or something like that. We don't need to get into the clinical appropriateness of these, categories that have been created.
Thanks, Jeff.
Can I ask the dumb non-clinicians question? This is Beth. So I defer to the clinicians, and I noticed a number of them nodding their heads, the clinicians on this work group on what you just said, Jeff. Sometimes the diagnosis matters a lot in terms of the treatment. Sometimes it's less, they're less tightly linked, is I guess I would say. So just in terms of, part of what we're trying to do is to get to a place where people are getting the care they need. So I'm just asking the question of, and I defer to the clinicians on all this, and it may be that the answer will change over time.
I think part of the challenge is diagnoses change over time as more and more history is taken. There's more and more trust between the clinician and the care team. And in fact, obviously, people's brains and their bodies change over time, and the context of their disease, quote unquote, changes over time. And so I think it's just sometimes a little too reductionistic to think of people as diagnoses or their symptoms as specific diagnoses. You're right, it can guide care, but I think that's really at a patient by patient level. Okay. And at this meta level, I think we should stay away from that more nuanced patient level diagnostic debate and tension. I just think that's dangerous water to get even close to, personally.
Thank you. That's very helpful because, not everything's like a bacterial infection where the antibiotic will work. There's lots of stuff in healthcare that's a lot more complicated.
Hi, Jeff. Tef from OHCA here. Can you kind of expand your comment on also the clinician variability of the same presentation? I think that context would also be helpful.
Yeah, what Tef is getting at is you could have the same patient present to 5 different clinicians, psychiatry and primary care, and potentially get 5 different diagnoses or different variations of diagnoses, which I just think underscores the diagnostic challenge in behavioral health. Or perhaps, as I said, you could question the underlying structure of how we decide what people's diagnoses are, and that might be the issue, not as much the clinicians themselves. And Tef, is that what I assume that's what you were alluding to? Am I?
Yes, thank you. Thank you, Jeff.
And Dr. Grumbach, Kevin, do you want to weigh in here?
Yeah, appreciate, Jeff, what you're saying, but I'm going to challenge a little bit because I actually do think by and large, there are some major categories in which patients or can be sort of sorted. I would say there are severe mental illnesses, schizophrenia, other forms of psychosis that are different from more mood disorders, anxiety disorders, and disorders that are primarily ones of substance use. Now, again, they're all often intersected with mood disorders and other types of issues. But I just think, the care patterns for somebody with severe schizophrenia is going to look very different than somebody who has, kind of adjustment disorder, form of depression, or even mild major depression. And that's going to look very different than somebody who's predominantly got an opiate use disorder. And again, not to say that there's not, each individual is complicated and there's a lot of intersectionality, but I do think if you look at patterns of care, I just think they're going to sort themselves very differently for where somebody with a severe mental illness sort of getting care and the kind of services that person needs compared to somebody with a moderate level of depression or somebody who really needs medically assisted, treatment for severe addiction.
Yeah, I agree. I mean, that level of categorization could be helpful. I think if we're getting down to more granular, though, like anxiety versus depression, like that is the granularity I think we should stay away from. So totally agreed. I think what you're saying is pretty aligned with what I'm saying, and recognizing even within some of those conditions, there's huge spectrum. Like major depressive disorder can be mild or severe, where somebody has tried to commit suicide 5 times in the last year.
Yeah, I think we're on the same page.
Thank you all. Anyone else want to add to this discussion before we move to our next question?
I'll just quickly note that I put this comment here about autism spectrum disorder and like where it falls, just because grouping that into like outpatient will distort the outpatient numbers, and so having it that a consideration. I guess this also gets back to what Kevin said about like psychotic disorders, and like you can create these bigger categories and that might fit into there.
Yeah, I would put childhood onset behavioral health would be its own kind of category. I think it has its own very unique patterns and different sorts of care patterns.
Carrie?
Yeah, I just wanted to put I guess a tiny, or maybe not tiny, but a caution there. I do appreciate the conversation on sort of the broad categories like mild to moderate versus, more serious mental illness. And I think, just because we may, as we're tracking spending, we may be spending more in terms of treating folks with serious mental illness. The more intensive treatment is not necessarily, doesn't necessarily lead to better health outcomes for all populations. And so just, I guess, again, not sure how to sort of track that, but I think it's, we would, again, just sort of stress that the, preventative care and that end of the spectrum, and then really want to look at, other factors as we're kind of moving up the scale of cost for more serious conditions.
Mm-hmm. Thanks, Carrie. Yeah, so I think just a takeaway for me for this conversation is it sounds like folks are interested in at least some categorization of the spending, but we'll need lots more discussion about how that happens. But it sounds like there is at least some interest in categorizing spending across different diagnoses or types of care. Okay, so we'll move on to question 4. And question 4 asked whether the behavioral health investment benchmark should focus on certain care settings like outpatient or inpatient settings. And here for the definition impact data, submitters would report their spending by these categories as defined by OHCA and through our process in the work group. So, reviewing data by these categories would offer insight into where behavioral health care is delivered and how it shifts over time. Moving in this direction would require, decisions about which care settings and which services in those settings to include, especially, among those decisions is how to treat behavioral health in primary care, which is one thing we've talked a lot about in our primary care work, and we'll continue to talk about the intersection here. And we should note that using care setting to define behavioral health is likely to increase burden on data submitters. And here, about 2/3 of respondents said that the benchmark should focus on specific care settings. So wanted to pause here for discussion and reaction for, the majority of folks, 67% responded that the benchmark should focus on certain care settings. Do folks have thoughts to, which care settings? Why are you seeing the emphasis on care settings? And Beth, I saw your hand first. Go ahead.
I would just to an observation and a question. The observation is that I know in other discussions there's been a lot of discussion about residential treatment and other settings. I wonder why, which seems contrary to focusing on specific settings. So I wonder why those who thought it was a priority to focus on specific settings suggested that. And so I think some discussion on that would be helpful.
Thanks. I'll let folks weigh in. Sarah, go ahead.
Beth, I think directly to that point, primary care is a setting, right? So when we talk about measuring primary care setting, we're actually defining a setting within the definition of primary care. Behavioral health services is a full continuum of services. It is not a setting. It is a inpatient acute to outpatient one-on-one intervention, right? And so I'm of the opinion that we have to measure that entire continuum and look at the entire continuum in its parts in order to understand the whole.
Yeah, I guess I'm just reacting to, and I see Hector on the screen, and he's a lot more expert on this than I am, reacting to the fact that people have chopped off various ends or parts of the continuum. We're for the continuum of care, and we're also for what Carrie rightly talks about, doing as much prevention as is possible, just like we're for that with high blood pressure and asthma and diabetes. That's to us. Good care is people staying healthy. But I do, especially in the behavioral health context, whether it's ABA and autism services, we fight that went on for a long time in the legislature, or residential treatment or other settings, I sort of wonder about, I understand ABA but it's delivered in the home. So for a long time, families with autism were told that isn't care because it's a family member delivering it in the home. So I think it just, the decisions we make here should be focused on making sure that people are as healthy as they can be, rather than, and I understand the need to focus as well. So that I would just be interested to hear others' discussion on this.
I mean, if I could just, I guess, respond to that, I guess I envision this as sort of place of service, creating setting, in my mind, maybe this is a bit different way to say it, settings equal sort of levels of care, maybe, right? And so you group those places of service into different levels along that continuum. But if we don't measure at each, I think we should measure the whole, but then also measure each spot, because like we might want more diversionary levels of care and less inpatient, but if we don't know how much we're spending on diversionary, how do we know to invest more there? Like we don't know that the balance is off.
Yeah, we don't know that people are ending up, well, I mean, we do. We all know anecdotally, and the people who are practitioners know practically, that people who could be cared for in other settings are ending up in emergency rooms, even though we could provide more appropriate and better care, we hope, earlier in a different setting.
Yeah, great discussion, Sarah and Beth. And Catherine, do you want to jump in?
Yeah, just really quickly, I think I was a yes on this one, although I didn't save my responses, so it's like looking at it anew. But I think my issue here is similar to Sarah's. I do think, and this ties back to the earlier discussion about concerns about out-of-pocket costs. I also read this as sort of a proxy for levels of care, and I think very important to understand where the spend is going now and where we might want to shift it to. And my thinking is, although I don't have the data at hand, that so much of that out-of-pocket cost is coming from people who are using outpatient services, for instance, less probably on the inpatient side. And I think that's the sort of thing we want to be able to track by service site. So my primary concern here was that we make sure to include the outpatient, but I think segmenting across these things, including residential, is important. And I think that's all I got.
Okay, got it. Thanks. And Hector, go ahead.
Yeah, thank you. I don't have much to add to what Catherine and Sarah were saying in response to Beth's question. I think the way I thought about this question was about categorization instead of excluding certain settings, right, or types of services, because precisely for that reason, because we want to measure whether there's more spending in a certain area like residential care, and whether we want to shift that spending to other levels of care. So it's not about selecting what's the best level of care at this point, but or rather about measuring where spending is going and adjusting if necessary. But we're not going to be able to know that if we don't categorize by the different settings. So that's the way I approached this question, but definitely don't. It wasn't meant to be thought of as let's just focus on residential while excluding something else. Rather, let's focus on everything, but making sure we have the different numbers for all of the settings.
Thanks, Hector. Carrie, go ahead.
Yeah, I just for us, just want to again kind of maybe try to articulate some of our thinking on focusing on care settings. I think, particularly, and I'll share a report we did several years ago with other groups, but with regards to the African American Black population, the mental health system has, offered inaccurate diagnoses, often disproportionate findings of severe illness, greater usage of involuntary commitments, and inadequate service integration. And, in essence, I think, when we think about what is the appropriate care setting, where do we want spend to go, I think we do need to look at, the particular settings, because sometimes there is an overdiagnosis or and a misdiagnosis at earlier stages, and we see these disparities. And so I think that's really the point that we've been trying to make about thinking about different spending, different levels of spending, and how those are not always tied to better health outcomes when we start looking at it from a population perspective. So I hope that's helpful, and I will share a background report that we worked on this. Thanks.
Thank you, Carrie. Yeah, so I think what I'm taking away from this discussion is that folks are interested in, categorizing spending by care setting or by levels of care. And I think one thing that I keep coming back to is it sounds like we're interested in tracking all, behavioral health spending as much as possible and, based on our kind of limitations that we know exist, but that there may be our investment benchmark may be a subset of total behavioral health spending, and that we may want to kind of focus our investment benchmark on a subset of total behavioral health spending. So I think it's really helpful. So we'll move to question 5. Again, here, question 5 was asked whether the behavioral health investment benchmark should focus on certain providers like psychiatrists or social workers. And here, in terms of how we would define behavioral spending to collect data in this way, that data submitters would use a list of provider taxonomy codes to submit their spending data by provider category. The work group in our work moving forward would consider whether all providers would be assigned to categories or just some. Either way, this would potentially increase data submitter burden to categorize spending in this way. A related note, all care could be measured. This is kind of going back to what I just mentioned, that, we could measure all care provided by certain types, but potentially restrict measurement to, but restricting measurement to certain providers would result in some undercounting of behavioral health spending. So that's just a consideration of, restricting by provider type. So here we had 63% of participants who are not interested in a benchmark focused on a specific set of providers, and about a quarter said they would be interested in focusing on a certain set of providers. Again, I'll pause here for discussion and reaction.
He's right. That's very difficult to say. It's been a tough
Stephanie?
I think that if you ever wanted to vote for Trump.
Hi, Stephanie Berry with Anthem. I think this goes to back to the issue, like we prioritized in my survey, the investment in an integration of primary care with behavioral health. And I think this focus on certain providers really misses again the issue of primary care providers in this space, and the fact that so many people, talk to their primary care provider about things like, mild to moderate, behavioral health issues such as depression, anxiety. And if we're really focusing on the taxonomy of providers, I think we're going to miss and undercount some of those key behavioral health spending that happens.
Thanks, Stephanie. Yeah, I think our intention is to capture behavioral health spending, or behavioral health care, or those behavioral health discussions provide in a primary care setting. That's our intention with we developed a behavioral health and primary care module that we will build out as we're working through our discussions on defining behavioral health. And we are including things like depression screening in our primary care definition. And as we move forward, we're looking to kind of really define that behavioral health in primary care module. So we are aiming to capture that spending. And if you had any other thoughts there, welcome you to weigh in, or we can chat more about that. Sarah.
My recommendation would be to have 2 categories with prescriber and non-prescriber in terms of taxonomy, because that's how you build networks differently. You build networks from prescribers and non-prescribers and track that separately. So that's my recommendation.
Thanks, Sarah. I think just to follow up on that, would that be, I guess, readily identifiable by taxonomy of the provider?
Yeah. Okay. There's only certain practitioners who have a scope of practice to prescribe. Arguably psychiatrists also can do non-prescribing, but largely what they do is prescribing.
Okay, interesting. Carrie, go ahead.
Yeah, this is just, I think, a question. If, without focusing on provider type, how would we capture, for example, the use of community-based providers like peer support specialists and others, given the, current disparities, for example, in language concordance for professionals, given the demographics in California.
So thanks, Carrie. I think the key here is, and welcome, Mary Jo and Vinayak from the Friedman team to weigh in here as well, that when we're thinking about if the behavioral health investment benchmark should focus on care provided by specific providers, we wouldn't want to track spending by provider type. But in terms of our overall definition of behavioral health spending, we would include those peer support specialists and community health workers and all of those types of providers, or, we can discuss how to include those and whether to include those providers. But I think, based on our conversations in primary care, that we would also include those in our behavioral health definition. And I think the nuance there is the non-claims payments that are used to pay for care provided by those providers. So we would look in our measurement of non-claims behavioral health spending to try to capture that spending as well. So I think there's a variety of different ways we could look at it, but it's, in terms of focusing the benchmark, it would be, do we focus on increasing spending by a certain type of provider? And it's, it sounds like, at least from the responses, that that's not a great interest. But maybe there's ways we would incorporate those all, a variety of providers into our definition.
Got it. That's helpful. Thanks, Margaret. And it sounds like a similar approach in terms of how we approached this on the primary care spending side. Okay, thanks.
Mm-hmm. Sorry, I'm looking for hands raised. Oh, Beth, go ahead, and then Amy.
Just on a question about categorizing providers by prescribers and non-prescribers, I certainly understand that there are many providers for whom prescribing is not within their scope of practice. Having won prescribing privileges for nurse practitioners and certified nurse midwives many decades ago. But I also am I would just be cautious, because I don't think the answer to every behavioral health problem is a prescription. And so we wouldn't want to encourage inappropriate or excessive reliance on prescribing as a modality. And so I think we just want to think that through. And it may be moot because it doesn't seem like we're focusing so much on type of provider, but that's just a caution we would have. I know, for example, at Covered California, that the consumer advocates felt very strongly that measuring prescribing as a way to measure management of depression was both inappropriate and failed to capture the underdiagnosis of depression. So I would just be a little cautious on that. Thank you.
Thanks, Beth. Amy, go ahead.
Margarita, I just wanted to just clarify what's the question we're trying to ask, because I think I was tracking you, right? We're not necessarily focusing spending by provider, right? But we just want to track prescriber versus non-prescriber. Because to answer this question, I just was wanting to better understand what's the actual question. What are we truly trying to clarify, trying to understand?
Yeah, Amy, really for all of these questions, the intention was to get, insight into the work group's priorities for behavioral health investment and use that to inform how we think about our conversations of definition. So, in our next work group meeting, we'll really dive into questions of how we define behavioral health spending. And a lot of these questions are like layers of how we could approach the definition. Like, do we approach by diagnosis? Do we approach by, care setting? Do we approach by certain providers? So really thinking about trying to use these questions to assess the work group's priorities for measuring behavioral health spending and increased behavioral health investment.
Got it. Yeah. So that's helpful. So I think what you're hearing, and I guess I'll concur for the record, is to not focus necessarily spending on certain specific providers. And I agree with Sarah's idea, right, of the prescriber versus non-prescriber in terms of taxonomy.
Mm-hmm. And I'll just flag that Sarah noted in that her comment was interested in measuring by prescriber versus non-prescriber, not necessarily setting a benchmark related to that lens. Thanks, Sarah. Okay, let's see. Jeff, did you want to jump in?
Sure. I mean, I think Amy's question I put in the chat, I agree. I think that's a key question. And Sarah, thank you for providing that context. I think if we were doing goal setting, that could have some distinct unintended consequences. And I think some of the push-pull around what you mentioned, Sarah, and then what Beth mentioned, it is very true. Many psychiatrists, if you talk to them, would like to be doing more psychotherapy and not just doing med management. Their scope of practice is obviously much broader than just pushing medications. And I'll use that in a judgmental way, purposefully. Beth, given your comment, obviously meds have their role and med access is important, and psychiatrists would like to be doing more comprehensive care themselves, but also recognizing, of course, the prescribers are the only ones that can prescribe medication. So there's this tension that develops between these two things that is a real challenge. And so I think there could be value in having these two categories, but being very clear about what question we're trying to answer. Is this hypothesis generating? Is that where are we trying to go with this? I think is really important, because if we don't define that, we're going to get into some really uncomfortable political territory with professional associations and others about what we're trying to achieve with this. So I just think we may need to continue to think about the pros and cons of these categories and the impact and what we're trying to achieve.
Thank you, Jeff. Appreciate that. Beth, did you want to add anything else?
Oh, thank you. It is exactly that kind of discussion that I think we need to have if we go into a focus on prescribers versus non-prescribers. I would also say that discussion would intersect with the appropriate levels of care, because prescribers tends to mean physicians. And as important as physicians are and as useful as medicine is, it's not the only form of care. So, and I think particularly in behavioral health. So thank you.
Sure, thank you. So I'll move us on to question 6. And this was our last poll question, and then we had an open-ended question. So question 6 asked whether the OHCA behavioral health investment benchmark should focus on certain populations, such as adults or adolescents. And here, in terms of the definition impact, data submitters would report their behavioral health spending using data elements representing the population characteristics in the definition. So a population focus for behavioral health spending benchmark would mean that spending for individuals outside of this population would not be included in progress towards the benchmark, but could be in our broader measurement scope. So we could measure spending broadly, but have a focused benchmark on a certain population. So about half of the respondents said that the benchmark should not focus on certain populations, while nearly a third said that it should, and the rest were undecided. So wanted to pause here again for discussion, conversation, any reactions to this? Anyone? Go ahead, Sarah.
Personally, I'm very interested in the population of early onset psychosis as a specific population to focus on. That and trying to, I don't even trying to measure the spend would be very challenging. But of all the populations that have extremely poor health outcomes and sort of financial cost to the systems in so many ways, is that group that we tremendously underserve. And so that's one population that I would elevate as warranting an entirely different care model and level of attention across the systems.
Thanks, Sarah. Anyone else want to weigh in here? Go ahead, Hector.
Thanks. I think I responded yes to this question because I'm interested in the evaluating levels of spending between differences between adult populations and younger folks. In particular, because we know there's a lot of issues with young people accessing substance use disorder services. So it will be interesting to look at that level of detail if possible. So again, talking about categorizing rather than excluding. Like, I wouldn't support excluding adolescents or young people and just focusing on adults. Categorizing is something that I'm interested in. The other population division that I would be interested in is rural versus urban. That's something that is also there's a lot of problems with accessing care in rural communities. So it's the extent that's possible. It's something that could be interesting to evaluate. This is also a question where we could think about it from an equity perspective, but I know that could be more difficult to obtain demographic data and other data like that. But I think all of those questions, to the extent that it's possible to get more data, would be helpful to understand how behavioral health spending is being delivered. Thank you.
Thanks, Hector. Yeah, I think that's something we'll have to think more about in terms of the rural versus urban and any other like lenses we could take to the data collection. I think, another possibility may be looking at, behavioral health utilization or behavioral health, spending using the HPD by different geographic areas. So we'll think about that more. And Amy, go ahead.
So I think that if we're looking at the lines of business that currently exist for the medical spend, right? We do have Medicare Advantage, we have CHIP, so we do look at these populations separately from a medical spend. And so my opinion was or my line of thinking was, if we're trying to integrate the two, if we're trying to get a better understanding of behavioral health spend, we should also align with medical spend.
Yeah, thanks for that flag, Amy. Yeah, we're collecting, primary care spend and more broadly, total healthcare spending by market. So, by Medi-Cal, Medicare Advantage, by commercial markets. So I think we would generally take that same approach here for behavioral health. And, in a sense that can show a little bit about different populations. Carrie, go ahead.
Yeah, well, I think that was going to be sort of my question, because I think, we are interested in understanding, differences in utilization and spending and outcomes by population, by demographic, race, ethnicity, language, other populations. And so as long as we're able to track that, I think that, that would be important if we're trying to reduce disparities. But it's, yeah, I understand there's so many, there's a lot of different factors to consider. So I don't know, how you all are thinking about this, but I think we would be interested in that conversation.
Thanks, Carrie. I think there's, the one potential challenge is just the nuance of data collection and the granularity of data collection from the data submitters, and how nuanced we're able to get in that data collection versus in OHCA's data collection versus maybe some of these questions might be better suited for us to look at through using the HPD. So we can think about that more. So, Sarah, I see your hand raised. Did you have anything else you wanted to add? Okay. I'll move us on to question 7 since we're getting close on time. So question 7 was our open-ended questions asking if you all had any additional comments or suggestions. And we had a variety of interest here. So work group members expressed interest in a benchmark that focused on adolescents and early psychosis program spending, both interest in looking at both conditions and care settings, and an emphasis on increasing spending on quality evidence-based care. Additionally, folks expressed interest in capturing spending occurring in employee assistance programs as part of behavioral health spending, taking a broad approach to measuring behavioral health spending, and then looking at what exists and does not in terms of meeting needs of the population and appropriate care delivery. And then last, folks expressed interest in better understanding the relationship between categorizing measurement versus excluding from a benchmark calculation. And I think we've talked a bit about that today in terms of how we're thinking about, potentially categorizing behavioral health spending, but thinking about how we might have a more focused benchmark. And we'll continue to have that discussion as we move forward. So I want to pause here again. Any reactions or anything else folks wanted to add based on the discussion we've had so far, or any thoughts on what's been shared in the the additional comments? Okay, I will move us on to what we on the OHCA team thought were some of our key takeaways from the survey responses, and also lots of key takeaways from this discussion. So this list may be updated a bit. So just first, based on the survey results, there was interest from the work group in a benchmark that prioritizes access to the most appropriate care settings, that potentially focuses on certain care settings and does not necessarily focus on certain provider types. The results also noted a moderate interest in a benchmark that focuses on certain populations, and then there was mixed interest in a benchmark that focuses on certain diagnoses and certain populations. And in terms of free responses, the OHCA team has a few action items for our team to better understand the availability of data on employee assistance programs. So we're going to follow up and look into that in terms of how that intersects with the data that the health plans would be submitting to OHCA about their behavioral health spending, and to think through with you all about how we would identify high quality evidence-based behavioral health care and how we would incorporate that into either our definition or our investment benchmark. So those are a few things that we'll follow up on. I think, again, you know, based on the conversation just now with Carrie and Hector about looking at, you know, spending by different lenses, potentially geography, and or like demographic factors. I think that's another thing we can follow up on and think more about. So again, I'll pause here to see if folks have any thoughts or reactions to the follow-up pieces.
I think the only thing I would add, just kind of echoing my earlier comments, as we think through each of these, really trying to be crystal clear about what questions we're trying to answer, what goals we're trying to reach, and what the use case is. I think we could all come up with lots of kind of research questions, if you will, or hypotheses that we could test, and recognize this is not the forum or the effort through which to necessarily ask or answer all those questions. There are other avenues to do that. And the more we try to push through this effort, the more administrative work will go into collecting these data, the higher risk of inaccuracies in those data, and thus the less value we will get out of those data. So I think for me, personally, our goal should be to have as few things as we can measure as possible that are as high value as possible, that have clear use cases and match up against goals we're trying to achieve through this effort. If I kind of want to, think of it on a broader meta level, what is the archetype and framework with which we're trying to sort through some of the things on the screen.
Thanks, Jeff. Really appreciate that framing. I know we have 1 minute left. So any final thoughts from the group? Okay. I think Debbie, I'll quickly turn it over to you, Debbie, just to wrap us up and share our approach for the next meeting.
Great. Thank you, Margaretta. So just super quick, next month, we will review what we've covered today and summarize that, and then we'll begin with discussing OHCA's preliminary draft recommendations for an approach to measuring claims-based behavioral health spend based on all the input from today. And just a reminder that our work group meeting for November has been moved to Thursday, November 21st. So it's not at the usual third Wednesday time. That should be on your calendars. And that's it for today. Thanks so much for the really robust discussion, and feel free to reach out between meetings with any questions or comments.
Thank you all.